coming. Oh, you're welcome. Sometime. Oh, we can wait.
Hello, everybody. Hi. So we'll have some more people filtering in here, I'm sure, but just since it's the top of the hour, I'd like to get started. Good afternoon. Welcome to the CM Seminar Series for March. My name is David Winchell. I'm the chair of the seminar series. It's great to see you all here today. Anyone who's dialing in, please just make sure to mute your line so that there's no background noise during the presentation. So by way of background, the CM Seminar Series was created originally to provide a forum for CMS employees to learn about the work and activities of people in CM in particular, and to allow staff to have the opportunity to present their work to a larger audience. And as I'm sure you'll agree, there's a lot of really exciting work going on across the agency, and we're really thrilled to be able to showcase some of that work here today. Gives me great pleasure to introduce our speaker for today, Liz Flo-Delwich. Liz works in the Division of Consumer Assessment and Plan Performance, or DCAP, in the Medicare Drug Benefit and C&D Data Group, or MUDBUG, which is part of CM. Her formal education includes an undergraduate degree in engineering, a master's in teaching mathematics and applied sociology, and a doctorate in public policy with a specialty in program evaluation and analytic methods. Before beginning her career at CMS, she was an associate professor of mathematics at a local community college, and also served as a research associate for the Maryland State Department of Education. She's worked at CMS for approximately 4.5 years, beginning as a student intern in CCSQ in 2011. And prior to her position in DCAP, she was the lead for the design and development of the quality rating system for health plans offered in the marketplace. Currently, she serves as the statistics lead for the Medicare Star Ratings program and also leads the development of the Emergency Department Patient Experience of Care Survey. So please join me today in welcoming Liz as she presents to us on Reach for the Stars, Medicare Advantage Star Ratings Response to Socioeconomic Status.
Thank you. Okay, if you can't hear me, just let me know. So hello, this afternoon I'll present a high-level overview of the development of the MA Star Ratings program's response to the impact of socioeconomic status on the ratings. Please note there is a slide number in the lower right corner, and for those of you who are not watching on YouTube, if you have a paper copy, I will provide the slide number at the transition slides. The presentation will provide an opportunity for questions at the end. I'll also be providing my email address should you have any questions at a later time. As displayed on this slide, I have an ambitious number of goals to cover during the presentation. Slide 4. I want to begin by clarifying some terms that will be used throughout the hour. The first set of terms are directly related to today's topic. There are also a number of statistical terms that will be defined during the presentation as well. A dual or dual eligible beneficiary is an individual who is enrolled in both Medicare and Medicaid. A low income subsidy, which I'll be referring to as LIS, helps beneficiaries purchase prescription drugs. All dual eligible beneficiaries receive LIS. A non-dual eligible beneficiary can also receive LIS through an application process. LISDE is a beneficiary who receives a low-income subsidy and/or is dual eligible. For the 2014 Star Ratings year, over a quarter of the MA beneficiaries were LISDE, disabled, or both LISDE and disabled. These percentages are relatively stable over time. Later during the presentation, I will mention case mix adjustment and refer to measure stewards. A measure steward is the developer and owner of the measure. Only the measure steward can modify the measure specification. A measure specification details not only the data to be collected, but also the methodology to report and calculate a measure. The National Quality Forum, NQF, reviews and endorses measures. Many of the star ratings measures are NQF endorsed. Socioeconomic status, SES, refers to the social standing of an individual or group and is commonly measured using the proxies education, income, and occupation. Broader or more comprehensive measures of SES that include access to material and social resources would use the definitions of socioeconomic position or sociodemographic status. Section 2D of the Improving Medicare Post-Acute Care Transformation Act of 2014, known as the IMPACT Act, requires HHS, acting through the Assistant Secretary for Planning and Evaluation, ASPE, to do a study examining the impact of individuals' SES on quality measures and resource measures under Medicare. ASPE, in turn, asked the National Academy of Medicine to define and conceptualize socioeconomic status. They concluded the framework for the impact study should be that of social risk factors and not SES. Social risk factors are factors that are related to health outcomes. There were 5 categories identified as noted on this slide. Slide 11. Next, I'm going to provide some background on the MA Star ratings. One of CMS's most important goals is to improve the quality of care and general health status of Medicare beneficiaries. Each year, CMS publishes the Part C and D star ratings to incentivize quality improvement, assist beneficiaries in finding the best plan for them, and determining the quality bonus payments. The first ratings for both Part C and D were displayed in the fall of 2007. The ratings are released in October of each year. The rating year uses the year of the upcoming open enrollment. So this past fall, October 2016, the 2017 MA Star ratings were released. The 2017 star ratings were based on up to 47 measures. The measures span 5 broad categories, including outcome measures, which reflect improvements in a beneficiary's health and are central to assessing quality of care, and process measures, which capture the health care services provided to beneficiaries. Each year, we review the measure set, considering the reliability of the measures, clinical recommendations, feedback from multiple stakeholders, and data issues. We are moving toward more outcome measures. Some measures move to the display page and are not used for the star ratings calculation, but are still monitored. The National Committee for Quality Assurance, NCQA, and the Pharmacy Quality Alliance, PQA, are measure stewards for a subset of the star ratings measures. The majority of measures used in the MA star ratings are NQF endorsed. Within the star ratings, similar measures are grouped together and they're referred to as domains. The MA star ratings has up to 9 domains. There's a hierarchical structure to the star ratings. The basic building block is the measure. The measure score is converted to a measure level star rating. This conversion uses cut points that are determined using a hierarchical clustering algorithm and a 1 to 5 star metric. Ratings at higher levels, domain, summary, and overall, use the measure level star ratings. It's important to note that the rating system is not an average of averages. The overall rating, for example, uses each measure level star rating along with its corresponding weight for its calculation. Given the pivotal role of the star ratings in achieving our goals, CMS reviews the measures and the methodology used to generate the ratings. We remain cognizant of the unique challenges of serving traditionally underserved subsets of the population. Next, the issue, slide 17. Multiple MA organizations and PDP sponsors believe that enrollment of a high percentage of dual-eligible enrollees and/or enrollees who receive a low-income subsidy disadvantage their ability to achieve high star ratings. In other words, they believe that the ratings are sensitive to the composition of the beneficiaries enrolled in a contract. Similar claims have been made about other Medicare quality measurement programs such as hospital quality reporting and the ESRD quality incentive program. There are two distinct aspects of the LISDE and/or disability issue: quality and payment. The MA Star Ratings program focuses on accurately measuring the quality of care provided, so the response that is to be developed must focus on enhancing the ability to measure actual quality differences among contracts. Slide 20, selected SES work. In 2014, NQF convened an expert panel to determine if anything should be done about sociodemographic factors in relation to outcome performance measurement, given the growing body of evidence that sociodemographic factors affect patient outcomes. NQF's general policy is not to adjust for sociodemographic factors, in part because of their link to disparities. The panel recommended that sociodemographic factors should be included in risk adjustment if there is a conceptual relationship between a given factor and the specific quality metric, as well as empirical evidence of the association. In addition, NQF initiated a 2-year trial period that allowed risk adjustment of performance measures for SES and other sociodemographic factors beginning in 2015. The initial findings of the report are expected in the next month or so. In 2015, MedPAC released a report and also examined factors affecting variation in the MA Star ratings. In the September 2015 release, MedPAC compared our initial findings that were detailed in a public release and presented in the 2016 draft call letter, and noted the alignment with their research findings. Further, MedPAC outlined possible approaches for addressing the sensitivity of the ratings that included a strategy of population grouping. From January 2016 to January 2017, the National Academy of Medicine, also known as IOM, released 5 reports commissioned by ASPE to report their study under the IMPACT Act. In December 2016, ASPE released their first report to Congress, which examined dual eligibility, residence in a low-income area, Black race, Hispanic ethnicity, and residence in a rural area. Disability was also examined. They had 2 main findings. Number 1, beneficiaries with social risk factors had worse outcomes on many quality measures, regardless of the providers they saw, and dual enrollment status was the most powerful predictor of poor outcomes. The second finding was that providers that disproportionately served beneficiaries with social risk factors tended to have worse performance on quality measures, even after accounting for their beneficiary mix. In February 2017, NCQA proposed revisions to 4 measures used in the MA Star ratings that would specify stratified reporting. The stratification would be by LISDE only, disabled only, LISDE, and disabled, and neither LISDE or disabled, as well as the overall rate. The comment period for the proposed change just recently closed, and next month we'll be receiving a summary of the comments. Case mix adjustment, sometimes referred to as risk adjustment, are statistical methods to control for patient-related factors when determining performance measure scores. By using case mix adjustment, you're trying to level the playing field. Okay, sorry. In other words, you're trying to answer the question how a plan would do compared to all other plans if they had the same composition of enrollees. There is a concern about the unintended consequence of adjusting away real differences in quality when considering adjustment for socio-demographic factors or social risk factors. I'd just like to point out that this is the only slide in the entire deck that has a mathematical equation. Total contract difference equals between contract difference plus within contract difference. Much of the research in the field includes a discussion of the decomposition of the total differences to between and within differences. The NQF technical report, as well as ASB's research and our research, delineates the terms as well. Within contract differences are differences that may exist between subgroups of enrollees in the same contract. For example, if LISDE enrollees within a contract have a different mean or average performance on a measure than non-LISDE enrollees in the same contract, these differences may be favorable or unfavorable to LISDE and or disabled beneficiaries. Between contract differences are possible additional differences in performance between contracts associated with the contract's proportion of LISDE and disabled enrollees that remain after accounting for within contract disparities by LISDE and disability status. For example, if LISDE and or disabled beneficiaries are more likely than other beneficiaries to be enrolled in a lower quality contract, then the between contract differences may represent true differences in quality between the contracts. Our research focused on within contract differences as well as ASB's report to Congress and NQF. Slide 24. To provide a framework for a response, policy goals were developed. The goals guided the response and included recognizing the challenges of serving vulnerable populations, proposing adjustments that reflect the actual magnitude of the differences observed in the data, providing valid quality ratings, providing incentives for MA and Part D quality improvement, and recognizing the need for options that are both transparent and feasible for the plans and CMS to implement. A key goal of the MA program is to achieve greater value and quality for all beneficiaries. So there were some additional policy response considerations for the approach which underscored our goal. These included a data-driven approach focusing on within contract differences that did not distort any signal of the star ratings. With support from our contractors, we have and continue to conduct research to provide scientific evidence as to whether MA organizations or Part D sponsors that enroll a disproportionate number of vulnerable beneficiaries are systematically disadvantaged by the current star ratings. CMS described the extensive research in the 2016 and 2017 call letters. We also released 2 PowerPoints and a technical appendix of the research findings on cms.gov. In addition, we issued a request for information to gather information directly from organizations because we believe that contracts are uniquely positioned to provide qualitative and quantitative information that is not available using our data. We also conducted numerous brainstorming sessions within Mudbug. Given my experience at the Department of Education, it was very exciting because many of the issues that were encountered in the field of education as trying to measure the academic achievement, giving disparities, overlapped with healthcare. We reviewed research conducted by others, such as the reports by NQF and MedPAC, and we worked across centers within CMS and with our HH partners and stakeholders. Since ASBE's work closely aligns with ours, we have and continue to collaborate with them on a regular basis. Further, we have engaged NCQA and PQA to examine their measures to determine whether a measure specification change is warranted. Not all measures in the star ratings are appropriate for adjustment for socio-economic or demographic factors. A subset of the MA star rating measures were examined. A measure was excluded from analysis if it was already case mix adjusted for socioeconomic status, like CAPS measures. The focus of the measurement was not a beneficiary level issue, but rather a plan level issue. The measure was scheduled to be retired or revised, or the measure was applicable only to special need plans. Our research focused on 16 measures as listed on this slide. Slide 31. There is an overlap in the LSDE and disabled status groups. Our preliminary research indicated the possibility of a disability effect, so we included disability in our analysis as well. For purposes of our research, disability status was determined using the variable original reason for entitlement, or ORAC. LISDE status was determined by using data in the IDR, and a beneficiary was flagged if he or she at any point during the year received a low income subsidy and or was dual eligible. In our 2016 final call letter, we reiterated our belief that additional research was needed to better understand and identify underlying factors that were driving the observed differential in performance between LISDE and non-LISDE beneficiaries. Our research was and continues to be comprehensive. Due to the matter of time, I am told I only have an hour and not 10, I'll just highlight 2 of the studies. We examined the association or relationship between the clinical quality outcomes of the subset of the 16 measures and LISDE and or disabled status. To answer the question, is there a relationship between outcomes in LISDE and or disability status? To do this, we estimated the average within contract disparity employing a logistic regression with contract fixed effects. The odds ratios were then examined. Well, so how does one interpret an odds ratio? Slide 34 provides some guidance, but I'm going to opt for an abridged edition of this slide. So how does one interpret an odds ratio? First, you have to identify the comparison group. LISDE or disabled will be compared to non-LISDE or non-disabled. So, if the odds ratio is 1, there's no association. If it's less than 1, it's a negative association. If it's greater than 1, it's a positive association. So here are the results. If the odds ratio is blue, its value is greater than 1. And this indicates a statistically significant positive effect of being LISDE or disabled. This means that LISDE or disabled beneficiaries are more likely to have the recommended care. If the odds ratio is orange, it indicates an odds ratio less than 1, and if it's black, it's an odds ratio of approximately 1. Seems pretty easy, but there are two things you have to remember. Number 1, correlation does not prove causation. And number 2, odds ratios can be misleading, which leads to a discussion of the difference between practical or meaning significance and statistical significance. Because we had very large sample size, results can be significant, but are not meaningful. This slide provides the odds ratio for the remaining measures. The findings were somewhat mixed. Most associations were negative, but not all. There was a fair amount of overlap between the association based on LISDE only and disabled status only. The next highlighted study examined the within-contract differences across contracts and sought to answer the question, is there a difference in performance or enrollees who are LISDE versus non-LISDE within contracts? And a sub-question, does this disparity vary by contract? To do this, we fit a linear mixed effects model that included LISDE as a predictor and random effects for contract, and included an interaction term of contract and LISDE. For each contract, the proportion of beneficiaries receiving the measured clinical process or outcome for LISDE and non-LISDE were estimated separately. And then the difference between LISDE and non-LISDE was calculated. The results are presented in a picture format. As they say, a picture speaks 1,000 words. What is this one saying? Let's take another look and just focus on one particular part of the visual. This example is for breast cancer screening. The horizontal scale at the bottom represents the difference in LISDE and non-LISDE performance rates per contract. The red square represents the median difference between LISDE and non-LISDE rates for the measure for all contracts. The width of the white rectangle represents the range of the middle 90% of the differences, in this case LISDE minus non-LISDE for contracts. And then the length of the blue line provides the overall range of within contract differences for contracts. I want to just note this is not a box and whisker plot. So let's take another look at the picture, and we can see the results are mixed. Okay? The majority of measures had a small negative within contract difference or no difference. For one measure, the LISDE beneficiaries had better outcomes than the non-LISDE beneficiaries, and this is reducing the risk of falling, which is strictly in the unshaded region of the visual. For disability, we did the same analysis. So, the answer to the question, Is there a difference in performance for LISDE versus non-LISDE within contracts? There is evidence of differences in performance between LISDE and non-LISDE in disabled and non-disabled within a contract. The overall variability of the within contract disparities differed across measures. The median within contract disparity indicated a small LISDE or disability effect. For some measures, the LISDE or disabled group outperformed the non-LISDE or non-disabled group. As mentioned earlier, an RFI was issued in 2014 that sought analyses and research that demonstrated that dual status causes lower MA star ratings and/or research that demonstrated that high ratings can be achieved when serving dual beneficiaries. We received over 65 submissions. They varied in content, evidence, statistical rigor, and data sources. We carefully reviewed each submission. The RFI provided insight to the practices that have been successful by receiving high ratings and serving LISDE and disabled beneficiaries. In the 2016 draft call letter, while in the midst of researching the LISDE disability effect, CMS proposed a reduced weight for a small subset of measures that revealed an effect in our preliminary research. Based on the feedback, CMS did not move forward and instead opted for additional research to develop a different approach. This decision was supported by the majority of our stakeholders. In the draft 2017 call letter, CMS proposed the Categorical Adjustment Index, or CAI. The CAI maintains the integrity of the star ratings and the core of its methodology. It affords us the ability to be nimble and reactive to changes in the landscape. It's flexible and allows modification. Further, it allows the release of the values in the draft call letter well in advance of their use in the ratings. The Categorical Adjustment Index is an interim analytical adjustment that is a factor that is added to or subtracted from a contract's overall and/or summary star rating. It adjusts for the average within contract performance disparity. So if you think about the methodology, it's really only 5 steps. That's not bad. There's a catch. There are 2 pre-steps. The first one has 4 steps, and the second one has 5. Takes about 20 slides to review the methodology at a high level. So let's start. The first pre-step. It consists of 4 steps. First, the measures to be adjusted need to be selected. The adjustment of the measure score approximates case mix adjustment. There had to be rules developed to decide which measures to select. The first rule, using the visual that we just reviewed, the median absolute difference between LISDE and non-LISDE beneficiaries had to have an absolute, again, difference of 5% or more. This first rule, using 5%, takes into account the impact of outliers on central tendency of the within contract differences distribution. There is no book to look up this rule. Instead, we had to rely on statistical norms. The second rule, no contracts that had the LISDE subgroup outperform the non-LISDE subgroup within a contract. The second rule uses the entire distribution instead of a trimmed range, let's say the middle 90%, to create incentives for contracts to provide the highest quality of care, Thus, the comparison must be all contracts. A table of the descriptives along with specific values corresponding to cut points in the distribution of the LIS-DE differences were released. Applying the rules to this picture results in 7 measures that would be adjusted for the 2017 star ratings calculation of the CAI. So these are the 7 measures that were adjusted. In the next pre-step, all adjusted measure level star ratings are determined. To do this, a beneficiary level regression model with indicators of LIS-DE disability status and contract fixed effects is employed to determine the adjusted measure score. Again, because we are focusing on within contract differences, it is important to have a model with fixed effects. Once the score is adjusted, the measure level star rating can be determined using the unadjusted cut points for that particular measure. Next, the adjusted summary and overall star ratings are calculated. I'm referring to an adjusted summary and overall star rating because these are using the adjusted measure level stars for the 7 measures. All of the other measures remain the same. For the unadjusted summary and overall star ratings, those are calculated just using our traditional methodology in a traditional year. At the end of the above pre-steps, adjusted summary and overall star ratings and unadjusted summary and overall star ratings are available for use. Now on to pre-step number 2. The goal is to have each contract classified into an initial group. To do this, you first have to examine the distribution for LIS-DE and disabled percentages for all contracts. You'll note when you're looking at the visual on the left for LIS-DE, most contracts either have a lot of LIS-DE enrollees or very few. There are very few contracts that have a mid-range of values, and you can see that from the height of the bars in the 20 to 90 range. If you look at the distribution for percentages of disabled beneficiaries within contracts, you'll see that there are not a lot of contracts that have a high percentage of disabled beneficiaries. The contracts are then divided into equal-sized groups. How many equal-sized groups? You do this by iteration. In 2017, for the 2017 star ratings, we divided contracts into 10 equal-sized groups, or deciles, based on their LIS-DE percentages. The same thing is done using the disabled percentages. In this case, we divided the contracts into quintiles, so 5 equal-sized groups. Again, the reason for this is based on the distribution of the percentages for LIS-DE versus disabled. Next, each contract is classified into an initial group based on the contract's percentage of LIS-DE and percent disabled. All we have to do is apply the fundamental counting principle to realize that if we have 10 choices for LIS-DE groupings and 5 for disabled, we end up with 10 times 5, or 50 initial groups. At the end of the above pre-steps, Each contract is categorized into an initial group, again, based on its percentage of LISDE and disabled beneficiaries. So, after pre-steps 1 and 2, we have adjusted summary and overall star ratings for each contract, the unadjusted summary and overall star ratings for each contract, and each contract has been classified in an initial category based on the percentage of LISDE and disabled for that particular contract. Now we can start the 5 steps. The goal of the next steps are to determine the values for the CAI. At this point, again, we have 50 initial groups as displayed on this slide. And if we just focus on where the X is, we look within each category and we calculate the mean adjusted and unadjusted star ratings, and then the mean difference of the adjusted and unadjusted star ratings for all of the contracts that fall within that particular initial category. Okay? So there ends up being 50 values that are being calculated. The final 3 steps are done to determine the final adjustment categories, FACs. Okay? At this time, the mean differences per group are available for each rating type. So there would be a table for the overall rating, there would be a table of values for the Part C summary rating, and also for the Part D summary. Okay? Let's just focus on the overall rating. What has to happen next is the collapsing of the initial groups to final adjustment categories. So you might say, how is that done? It's not that bad. The initial categories are collapsed to form the final adjustment categories in a manner that enforces monotonicity. What that means is as the percentage of LISDE or disabled increases, the value of the CAI should increase. So if the CAI is developed or is being implemented to address the sensitivity of the star ratings to the composition of the enrollees in the plan, it makes sense that as the percentage of LISDE and or disabled increases, the value of the adjustment should increase. We also try to maintain a minimum number of contracts in each final adjustment category. And if possible, the initial categories are collapsed such that the CAI values will differ by at least 1/100th of a unit. The units are actually stars in at least one of the 2 dimensions. Step 5 results in the CAI values. So again, in the table that is displayed on the slide, you can see in 2017, in the 2017 star ratings, there were 8 final adjustment categories. To determine what the particular value is for the CAI, let's say for the overall star rating, this table would be used. A contract would have to determine its final adjustment category. We also provide it to the contract to confirm that they are aware of their final adjustment category. And then the CAI value is either added to or subtracted from the unadjusted overall star rating. So there are a number of different CAI values. Each contract has up to 3 mutually exclusive adjustments. For example, an MAPD would have a CAI value for its overall star rating, a different value for the Part C summary rating, and another one for the Part D summary rating. PDPs would only have one CAI value that would be applied to the unadjusted summary rating for Part D. For the 2017 star ratings, the application of the CAI resulted in modest movement of the stars. In the overall ratings, 9 contracts did change from an unadjusted score of 3.5 to an adjusted score of 4. Again, the CAI values are to the nearest millionth of a star. The contracts that changed from 3.5 to 4 stars did not receive a half-star adjustment, but rather, once the CAI value was added to their unadjusted overall rating and the rating was rounded, the value went from 3.5 to 4. For Part D, the movement was a little different. 9 PDPs decreased a half a star and 3 PDPs increased half a star. In the draft 2018 call letter, we proposed continuing the use of the CAI. The majority of the commenters were in complete support of the CAI. Also, if considering the number of comments received to the 2018 draft call letter, there were less than half the number than compared to 2017. Further, in the draft call letter, we proposed the measures to be adjusted. For the 2018 star ratings, for the 2018 draft call letter, we proposed 5 measures to be adjusted, using the same rules as we did in 2017. We are committed to building the foundation for a long-term solution. Presently, we're reviewing ASPE's considerations in the report to Congress. We're also continuing our research. We're also continuing our collaboration on a regular basis with ASPE and other HHS partners and stakeholders, and we are engaged in dialogue with our measure stewards for a subset of the measures, NCQA and PQA. Are there any questions?
Okay, great. Thank you so much, Liz. So yeah, we will take questions now. First, I'd like to start off with anyone who might be on the phone. Sorry, one moment. Anyone on the phone might like to ask a question. You're free to unmute your line and ask away. Okay, we'll come back to the phone. We have a question here in the room in the front. Would you mind going to the microphone? Yeah, thank you so much.
Hi, this might be a little bit naive, but as I listened to your description of the issue, which is dealing with the disparity, you were looking at correlates like disability and DE and trying to adjust. Just out of the top of my head, I thought a functional approach which would not use statistics might be better. Let me give you an example. If you have outcomes as a measure, it's one of your 5 measures, so I noticed that it was first. Clearly, a person without chronic disease is going to have a lot of good outcomes. A person with chronic disease, well, chronic means he's not going to get better. So they will have very little outcomes. So there's something deficient in the measure outcome. Now, if you look at those 2 cohorts, namely the cohort of people with chronic disease and non-chronic disease, and look at processes, the people who are not chronically ill will not have to see a doctor that often, where the people who are do. So what I was thinking is if you combine outcomes and processes in some manner, and I just looked at this, so I can't give you the details, but if you did that, you would have a measure with the following attribute. For any patient, forget about plans and providers, for any patient, there is the potential to score low or high. On the other hand, something like outcomes doesn't have that attribute. Something like processes doesn't have that attribute. What you're doing, in other words, what I'm claiming you're doing, is taking intrinsically deficient measures which do not have the property that they can be applied to any patient, and then adjusting for their deficiency. I think it would be less work and more productive if you simply took your existing measures, maybe added some more, and insisted on measures that have the property that for any patient there's the potential to go from high to low. And without using any statistics, obviously such a set of measures is less likely to have deficiency, because definitionally you've created them so that they could apply uniformly.
I think that's an interesting idea. One thing we have to keep in mind is that a number of these measures are under the control of measure stewards. So we're not free to do anything to the measure specification itself. So things such as excluding perhaps particular individuals or reporting the measures using stratification, which would somewhat get at what you were discussing, where we could have the measure broken down, which is what NCQA is actually proposing, looking at, well, how did LISDE individuals do, how did non-LISDE individuals do, et cetera. But that has to come from the measure steward. There's a number of different ways that actually would have a foundation similar to what you suggested, where you could use a method of indirect standardization, you could use a method of peer grouping. So instead of comparing LISDE to non-LISDE and trying to roll up the measure, you could actually report and do a report like that, which is what NCQA is proposing for just a very small subset of the measures, but doing a peer group, so you're only compared against like people, and then trying to do a roll-up some way. So I think, again, your ideas are right on the mark, and there's a lot going on, kind of thinking about how can we address this issue, and then how can we address it such that we don't go against the measure specification, and we keep to one of our goals, which is it has to be easy to understand. So, and I agree, there's a lot of statistical methods that we could apply that would be really cool and fun. But if people were to read the methodology itself, they might become perhaps a little unengaged with the document and think that things are behind a black box. So that is one reason why we developed the CAI, because even though it might have seemed scary, 20 slides and 5 steps and 9 pre-steps, overall it didn't seem that bad. And the methodology was pretty straightforward. But I think that there's going to be a lot of work, and I'd be happy to talk to you later about that as well. Thank you.
Oh, we have another question in the room.
Thank you, Liz. It was great and really interested. I remember that the Platino plans had argued that we were unfair in their measurements. Did any of their scores change as a result? Was there a massive switch one way or the other?
For plans in Puerto Rico? Mm-hmm. We did have an additional adjustment for contracts that were operating and serving beneficiaries specifically in Puerto Rico. And because Puerto Rico has a complex history and beneficiaries are not eligible for LIS, to be equitable in the application of the CAI, as you know, you have to use the percentage of LISDE within a contract for its categorization into an initial contract, which then also goes into a final adjustment category. So what we did for specifically for Puerto Rico is we developed an LISDE indicator, which provided an adjustment to their percentage, because the percent LIS would be 0, such that there would be an equitable application of the CAI. And we do detail that methodology in our technical notes in Appendix O, and I'd be happy to share that with you. You can email me, and I can send that to you. The scores did change in Puerto Rico. Another thing that we also did for contracts operating solely in Puerto Rico is that we reduced the weight of the adherence measures. We reduced them to 0. And then we also kept the weight of the adherence measures in the improvement measure. And again, this is just acknowledging that there are unique challenges for particular contracts, and so we did develop a specific response for the contracts in Puerto Rico.
Any more questions in the room here? Okay, we'll go. We have one on here in the second row?
Yes.
Great.
Thank you, Liz. You probably covered this, but could you just reiterate, were there certain aspects of SES or SDS race or income, whatever, that you could kind of parse out and say, this was the factor that was important? And
So-
also,
okay.
second part, and the bottom line is, so the critics are right. We should include these factors to adjust because we saw the stars change at the end.
We did examine the sociodemographic correlates of the HEDIS measures. And when we did that, and in combination with all of the other research that we have done, what we found, and the reason actually why in the 2016 draft call letter that we asked for additional time for research, is to see what was being picked up with the LISDE coefficient. And it turned out that that was statistically significant. So even after adding other controls in the model, LISDE was still the coefficient that had the most significant effect. And so that we did not move forward with having other controls in the regression analysis. In terms of, you know, is everyone right? Yes, we are right as well. Our research did show that there was an LISDE disability effect, but that effect was much smaller than what was perhaps perceived by the industry. And again, a lot of focus was looking, when people did realize a much larger effect, looking at total differences as opposed to within contract differences. And so it's very important as we move forward to keep in mind that we do not want to risk adjust away disparities, that we need to have a signal to beneficiaries and to other contracts about the quality of their plan. And so right now, we are just adjusting for that subset of measures. Again, only 5 measures for the in the draft 2018 call letter, and the adjustment that resulted from the application of the CAI in the 2017 star ratings was in alignment with the effect that our research revealed. Some contracts have tried to advocate for a just straight bonus added, but that wouldn't be in line with our policy goals, which underscore the importance of a data-driven approach.
Okay, I think we have time for just one more question. Oh, sorry, yeah.
Sorry, my question's very simple. So for some of the contracts that had an increase of half a point or half a star, were any of those not eligible for a quality bonus payment because they were below the 3 and now they are?
I'm sorry, they weren't eligible for a...
So I guess my understanding is that you're not eligible for a quality bonus payment unless you have a star rating of 3.
Of 4
Oh,
or
so
above.
you have to have a 4. So
Right.
so
then they became eligible for QBP with the change from 3.5 to 4. There are also rebates, and those are below 4, but our focus was on the slide deck. That's why I specifically had the 3.5 to 4.
and so
contract
I
slide.
think I recall you said that was for 2 contracts. Well, oh, that's okay.
Okay.
I think I have access to it and I can look at it.
Okay.
I was just curious if it really made a significant financial difference for some of these contracts, but it looks like.
For some of the contracts, if they change from not getting a quality bonus to having a quality bonus, that would make a difference.
Okay. Thank you very much.
You're welcome.
Okay, great. That's all for us today. I want to thank everyone for being here, and of course Liz for her time and energy in presenting for us. And if you do have any feedback or questions or any suggestions for future presentations, you can send them to our mailbox, which is cmseminarseries@cms.hhs.gov. And thank you again.
Great presentation.
Oh, great. Thank you.
So you understand what I'm saying now in terms of your answer? So outcomes and processes.